Hello everyone and welcome back. Several years ago, we presented our first time approach to the correction of right anomalous pulmonary venous connection performed robotically. Now we have a 36-year-old patient that presented with symptomatic aortic stenosis that incidentally was found to have anomalous pulmonary venous return. So let's have a look at how we solved both of these robotically. Patients can present with anomalous right pulmonary venous connection, draining the right upper pulmonary veins into the superior vena cava instead of the right pulmonary veins draining into the left atrium. And this is resulting in a atrial septal defect associated with the anomalous pulmonary venous connection. This can be repaired in a different manner, including the Warden procedure, which was propagated here at West Virginia University, or a patching technique of a baffling of the anomalous pulmonary venous return to the existing large septal defect, and then extending a patch to augment the SVC. So we had performed already the first such robotic performance in 2020 with this two-patch technique, and extending also the SVC. So now we'd like to present the first time these are combined with a patient that presented with severe aortic insufficiency, approximately 30-year-old gentleman. And in his workup, he was found to also have right anomalous pulmonary venous connection with a large septal defect. So this is the finding of the anomalous pulmonary venous connection here of the right upper veins. You can see the dynamic aorta due to severe aortic insufficiency. The aorta was entered. The direct corneosteal cardioplegic catheters were inserted, and the leaflets were excised after cardioplegic arrest. Sutures were then placed in the annulus, and a 23 bileaflet mechanical prosthesis was inserted in this young gentleman, and the aortotomy closed. Antegrade delivery of cardioplegia was then performed to continue his myocardial protection. And now, to expose the defect, several polypropylene retraction sutures were placed against the chest wall and brought out through the working incision to help retract this defect. Bicaval cannulation had already been established, but there is some flow through the septal defect. I did insert a snare here using simple umbilical tape, and I'll facilitate the complete drainage with an extra sucker. And now you can see both the large atrial septal defect as well as the anomalous pulmonary venous connection. And we elected to repair this by creating a fairly large baffle using bovine pericardium, commercially available. Starting first with an anchor bite to establish the size after trimming, and a secondary anchor bite. And the importance of this, we found, was to ensure there was no purse stringing of the baffle when it's created. This just follows surgical principles in adult congenital surgery. This was then followed by a running 4-0 polypropylene suture. And then we elected to use this quote-unquote two-patch technique with one patch by folding the patch as outlined here to create the complete baffle, making sure there was adequate redundancy. And once we were at the midline, we decided to add the second suture. Again, 4-0 polypropylene. and run this layer again in a similar fashion, keeping the anchor bites for stability. And you can see we have a nice opening without restriction here. And this completes the initial baffle by continuing in a running fashion. And this completes the first suture line. And now, again, with the retraction sutures in place, we wanted to make sure we had a nice, adequate extension, confirming the closure first of the first baffle and creating a very large extension patch to ensure excellent flow across the SVC. So here we are starting the other suture line, again using the same patch as with an anchor bite anteriorly, and then a running fluoropolypropylene. This is fairly straightforward. We've performed several of these types of cases, but this was the first time we did this in combination with a robotic AVR at the same time. We release the snares to allow the SVC to fill. We'll volume load just a little bit to ensure adequacy of the suture line as well. Here we are volume loading at this time. And with the heart filled, we'll do the final closure. And the heart is then reanimated. And postoperatively, we can see excellent laminar flow, complete closure of the atrial septal defect, and competence of the aortic valve with physiologic gradients. So we can combine robotic AVR with anomalous pulmonary venous connection.
So now we have seen how to do a RAVR in conjunction with repair of partial anomalous pulmonary venous connection. So join us in our next episode for a robotic transcatheter aortic valve replacement, or TAVR, explant.